Hi, this is Dr. Sham, and let's talk about a very important topic in cardiology, that is infective endocarditis. Let's start. What is infective endocarditis? So, infective endocarditis, it's an infection involving the endocardium, as the name implies. So, infection involving the endocardial surface. Endocardium is the inner lining of the heart that covers the heart valves, okay, the chorda tendineae, and the sites of septal defects, and the inner lining of the heart, of the walls of the heart, okay, the ventricles, atria. So that's the infection involving the endocardium. What happens is that typically it involves the valvular surfaces. What happens? A turbulent blood flow, say for example, that causes us injury to the endothelium, okay, to the endothelial surface, okay, of the endocardium. Um, what happens is then if there's an injury, then platelets and fibrin, they adhere to form a thrombus, and when there's a bacteremia sticks to that thrombus, leading to the vegetations, okay, and we have the vegetations in the infective endocarditis that we see on the, particularly in the valves, on echocardiogram. Risk factors involve, if we have a stenotic or a regurgitant lesion, acquired regurgitant or stenotic lesion of the valves, previous infective endocarditis is a risk factor. Then structurally congenital heart diseases, including surgically even corrected, but this doesn't involve isolated ASD or VSD that's completely surgically corrected. A valve replacement or implantation or cardiac devices, definitely that's a risk factor. Intravenous drug abusers, and the vascular access, the peripheral venous cannula or the central venous catheters, these are all other risk factors. Okay, the organisms next which are known to be associated with the infective endocarditis. The most important, Staph aureus. Okay, let's divide now which organism is most commonly involved in a native valve and which is going to be in the prosthetic valve. So in the native valve, Staph aureus is most common, as I said. So if it's a native valve, there is infective endocarditis. Okay, mostly it's the Staph aureus. In prosthetic valve, it's Staph epidermidis for first few months. Like first 2 months is the Staph epidermidis, that's more common, and after the 2 months it's again Staph aureus. Okay, then there's a link of certain organisms, like in a colorectal carcinoma. If someone is having that one, as gets infective endocarditis, so mostly it's Streptococcus bovis or galolyticus that's involved. Then poor dental hygiene. If someone is having and gets infective endocarditis, say for example, so it's Staph viridans, which is most commonly related with the poor dental hygiene, mitis and sanguinis. Then there's a hack group, Haemophilus Gatibacter, Cardiobacter, Echinella, Kingella, Coxella, Enterococcus, and some of the fungi. These are actually the organisms which are known to be associated with infective endocarditis. Okay, let's talk about the signs and symptoms. So patients present with the fever, chills. Okay, the fever and chill, that's the most common symptom. But those old people and compromised people, they may not present with a fever, to be honest. Cardiac murmur, then it's another common thing associated with the infective endocarditis. Anybody who is presenting with a fever and a new murmur, you should think of infective endocarditis. So a fever and a new murmur, infective endocarditis, until unless proven otherwise. Okay, then other constitutional non-specific symptoms: night sweats, fever, weight loss, myalgias. Then this weakness, arthralgia, headache, that's the symptoms of the embolic phenomena, okay, that can happen in the infective endocarditis. And then shortness of breath if someone gets a heart failure because of the infective endocarditis, because it typically involves the valve, so it leads to regurgitation and heart failure that leads to the shortness of breath. Then there are less common symptoms. These Janeway lesions, ocular nodes, splinter hemorrhages, which we read in every topic in infective endocarditis, these are the less common symptoms, by the way. Okay, so yeah, these are the rot spots you can see and on the retina. These are the Janeway lesions you can see in the palms and the soles. Okay, so we have talked about what infective endocarditis is, the organisms involved with that, and we have also discussed about um, the um, signs and symptoms. Okay. By the way, let's discuss a bit about the classification of infective endocarditis. So it could be acute, it could be subacute, it could be chronic. Then there's another classification like that's related to the valves and device, like native valve endocarditis, prosthetic valve endocarditis. Um, you can say device-related endocarditis, and then right-sided endocarditis. Right-sided endocarditis is more common in intravenous drug abusers. Okay, so the diagnosis, important three things, to be honest, or four things you can say: blood culture, echocardiography, FBC, CRPs, ECG. These are the most important. And then some baseline tests like liver functions, kidney functions test. But importantly, it's ECG, blood culture, echocardiography, full blood count, and inflammatory markers. Other tests which we can do in a patient with infective endocarditis is rheumatoid factor or immunological blood tests, ESR complement, CT, MRIs, and the PET scans. CT and MRI, you can see like they can give us a clue about the embolic phenomena as well. If someone is having that one, the embolic phenomena gets a stroke because of the vegetation, so they're helpful in diagnosing that one. Okay, importantly, as I said, blood culture. Okay, so anyone who is coming with a fever and a new murmur should give antibiotics and take blood culture. So what you're going to do is you're going to get 3 sets of blood culture from 3 different sites, taken 3 minutes apart, prior to the initiation of the antibiotics. But if the patient is unwell or with the sepsis, don't delay the antibiotic while waiting for the cultures. Okay, just take a culture, give antibiotic, and take the rest of the cultures if the patient is unwell. Otherwise, if you have the time, patient is not septic, is not unwell, then you can take like one culture. After that, 30 minutes another, and 30 minutes 3 shots, and then you should, from 3 different shots, and you should start on antibiotic. If the patient is very unwell, don't delay that one. Take one culture, give antibiotics, and take to the 2 rest of the blood cultures. Okay, so what you're going to do is that you're going to take the blood culture, you're going to give the antibiotics. Okay, and after 72 hours, mostly you have the preliminary report of blood culture. Okay, and you can change your antibiotics after that. Okay, we'll talk about these blood cultures and the treatment in a short while. Again, we'll be discussing the treatment. And next thing is the echocardiography. So the echocardiography is not only important for confirming or ruling out the diagnosis, but also the complication and the prognosis. Like if the vegetation is getting bigger and bigger, or it's persistent despite the antibiotic therapy. So echo is going to give us a clue regarding that one, and we need to think a bit forward now. Okay, so European Society of Cardiology that recommends anyone who is having a native valve endocarditis should be screened with T, and someone who is having prosthetic valve or having intracardiac device suspected endocarditis should get a TOE. T is transesophageal echo, and the TOE is T is transthoracic, and TOE is transesophageal echo. Okay. Here you can see a vegetation in the mitral valve clearly. Okay. So blood cultures, echo, and then is the ECG. So record an ECG. ECG tells you about the conduction abnormalities that can be in the infective endocarditis. Like we always look for the PR interval, because if the PR interval is prolonging, actually, so it tells you about the abscess, aortic root abscess in the infective endocarditis. But there could be the other abnormalities as well, like the AV blocks, first, second, third degree. These are uncommon, but they are related with the worse prognosis and higher mortality. Okay, so we talked about blood culture, ECG, and the echo. Okay, now let's move towards the diagnosis. So you have the Duke criteria is a major criteria and a minor criteria. So in the major criteria, the first thing is a positive blood culture. So a typical microorganism consistent with infective endocarditis in the two separate blood cultures. The organisms we have, we had a slide earlier. We saw those organisms which are known to cause infective endocarditis. So these are the typical organisms. If they come on a two separate blood culture, okay, that's one thing. Okay, that gives a 1 point in a major criteria. Okay, the other thing is the microorganisms which are consistent with the eye. Those microorganisms are continuously positive on blood culture. Greater than two positive blood cultures, which are drawn 12 hours apart, or all the three cultures you have taken, or greater than four separate blood cultures, which are drawn 1 hour apart. So the second thing is you have the microorganisms that are consistent with the IE. They are positive on continuous positive blood cultures, either greater than two who are taken 12 hours apart, or all the three you took earlier, or greater than four separate blood cultures, or a single positive blood culture that is positive for Coxella. So in all 3 points, okay, if all the three are positive, either one is positive, two is positive, so all of these carry 1 1 1 mark, okay. And then the second thing in the major criteria is a positive imaging. So if you have a positive imaging, or either on echo or a CT or a PET scan or a SPECT scan, so if you have a valvular lesion on any of these imagings, that's going to give you a positive criteria, 1 point in a major criteria. So we have actually discussed the four things in the major criteria. So we've got the four things, and each carry 1 mark. Then the minor criteria is that if you have a predisposing heart condition or intravenous drug abuse, that's 1 point. Fever greater than 38 is another point. Any vascular phenomena, that gives another point. Then any immunological phenomena, glomerulonephritis, ocular nodes that are the tip of the finger, rot spots in the retina, rheumatoid factors positive, either of them, that's going to give 1 point. Or the last thing is the positive blood culture that's not meeting the major criteria. Okay, so if you have the two major criteria positive, that's a definite IE. Or you have one major and three minors, that's definitive infective endocarditis. Or if you have the 5 minor criteria positive, it's definite infective endocarditis. Possible IE, if it's a 1 major, 1 minor, or the 3 minors, this is a possible IE. Okay, so this is the diagnosis, the Duke criteria. So you have got the major and you have got the minor, and then you have, based on numbers, okay, it's like either it's 2 major or 1 major, 3 minor, or 5 minor, it's definite IE, and 1 major and 1 minor or 3 minor, that's going to be possible IE. Okay, let's start with the antibiotics. Okay, what's the blood cultures you're going to give? You're going to start on the antibiotics. But again, the same thing, if the patient is very septic, don't wait for that one. Take a culture, give the antibiotic, and take rest of the 2 blood cultures. So 2 blood cultures, 3 blood cultures taken half an hour apart from 3 different sites. And it's always like checking your local guidelines, what is going to be the empirical antibiotic for infective endocarditis. So initial blind therapy, that's empirical. It could be a Fluclox with gentamicin. Okay, that's a sensible, but check your local guidelines. But Fluclox, gentamicin, that's the initial empirical therapy. And if someone is penicillin allergic, then give Vanc plus rifampicin. That's for the native valve. If it's a prosthetic valve, then the initial empirical antibiotic, when you have taken the blood cultures and patients having a prosthetic valve, give Vanc, Genta, and rifampicin. That's going to be empirical antibiotic. So you're going to take the blood cultures and you're going to give the antibiotics, and you will be having a preliminary report after 48 hours. And if you got an organism over there and they're sensitive, you can change the antibiotics. Okay, so then this was the first thing. That's a medical therapy. And there might arise a need for the surgery as well. okay, if the medical therapy is not working. Like if somebody is having persistent fever, okay, or the vegetation that's growing in the size is not reducing in the size, that means that your antibiotic is not working. So probably you need to think of the surgery. So the aim of surgery is to remove the infected tissue and to replace it and to restore cardiac anatomy. Now, what's the indication of the surgery? So indication of the surgery is if somebody who is having a cardiogenic and pulmonary edema despite the treatment, or poor hemodynamic intolerance, or someone who has developed the abscess, aneurysm, fistula, if someone is having a persistent positive blood culture despite the antibiotic for more than a week, or resistant bacteria or fungi, prosthetic valve caused by Staph aureus or non-hack. So these are the indication for the surgery. Okay. Or someone who is having a high risk of embolism if greater than 10 mm vegetation and emboli despite antibiotics, or greater than 10 mm vegetation, and there's another reason for the surgery, should go for the surgery. So surgery is actually when your medical treatment is not working, even if like in any case, like if the vegetations are persistent, if the organism is not responding to the antibiotic, the patient's having persistent fever, or if it develops the complication like the abscess, should go for the surgery. Okay, so how are you going to monitor this patient? So as I said earlier, 3 blood cultures. This is for acute endocarditis, infective endocarditis. 3 blood cultures, okay, taken half an hour apart from 3 different sites. Start the antibiotic. If patient is very septic, take a blood culture one, start the antibiotics, and take 2 rest of blood cultures. Okay, and then everybody, okay, in every of the patient should repeat the blood cultures, okay, after 48 hours. Okay, after starting the antibiotics, should repeat the blood culture, and then again repeating a blood culture at day 7. Okay, this is going to tell you these consecutive blood cultures, like you're taken 3 when the patient came in, another in 48 hours, and then another at the 7th day. That is there, and that's going to tell you that whether your antibiotic is working or not. So if somebody is growing a persistent positive blood culture despite the antibiotics, this means that probably your antibiotic is not working. So that's to check whether the antibiotic is working or not. Okay, so that's how you're going to monitor that one. Okay. What about the antibiotic prophylaxis? Well, ESC guidelines, they actually recommend that every person, a high risk person. High risk is someone who has got prosthetic valve, has got previous infective endocarditis. Okay, are these are the people who are the high risk people. If they involve any of the surgery that's involving the gingiva or the oral mucosa, the puncturing of that one, they should get antibiotic prophylaxis. The rest of the people is no need for the antibiotic prophylaxis, but that's only for the highest patient, someone who has got previous infective endocarditis, someone who has got prosthetic valve. Okay, these people. The prognosis, well, there's no studies for overall prognosis, to be honest, no comprehensive studies. Heart failure, someone develops a heart failure, that's single greatest predictor regardless of the organism. Yeah, definitely the other things, the old age, prosthetic valve, cerebral embolism, that are linked with increased mortality and the morbidity. Yeah, that is the thing. Last but not least, the duration of treatment is 4 to 6 weeks. And before the completion of the treatment, 1 week before the completion of treatment, everyone should have a repeat echo to set a new baseline. So I'm just going to put into a nutshell again. So anyone who's coming with a fever and the new murmur, suspect infective endocarditis, take 3 sets of blood cultures, half an hour apart from 3 different sites, and start the empirical antibiotic. If patient is very involved, take a blood culture, start the antibiotic, and take rest of the 2 blood cultures. Don't delay the antibiotics. Everyone should have a repeat blood culture at 48 to 72 hours, and then another repeat blood culture at day 7. Okay, the duration of treatment is like 4 to 6 weeks, and everyone should have a repeat echo before the completion of the antibiotic. So ideally 1 week before the completion of antibiotic. Those people who have the native valve endocarditis can have the transthoracic echo, but the people who are having a prosthetic valve endocarditis ideally should go for a transesophageal echo.